Why I am saying IFTA in 100%? Because at the age of 7 years old can be seen only Duchenne muscular dystrophies. This is the worst variant of the muscular dystrophies and having the high speed of the progression. And usually the debut of it can be seen in the age of 3, maximum 6. So how we can classify muscular dystrophies? Well, first, 6 sexually. Duchenne muscular dystrophies and Becker muscular dystrophies. Then, autosomal recessive muscular dystrophies. For one more time, we will discuss them much more detail. And autosomal dominant muscular dystrophy. It's 3 variants of classification. Oh, the illustration is how we see the clinical sign of the muscular dystrophies. So patients first complaining on the weaknesses on the proximal part of lower extremity. Due to this, for those groups of the patient, to have to change the posture from sitting position to the standing. And like in illustration describing, it seems like patient during trying the position, going in abduration by itself with the help of the hand due to proximal weaknesses of the muscle. The same, here we see hypertrophy of the muscle, particularly in the distal part of the extremity, yes? Then standing on the torque, and hyperlordosis on the dorsal region on the spine. Courses for the muscular dystrophy. So defects in certain genes, we said that much more percent of them genetic predisposed. This is mutation in the gene. The type of muscular dystrophies is determined by which gene is defective. Like Duchenne muscular dystrophies, and a little bit facts from the history. In 1986, researchers discovered the gene that, when defect, causes Duchenne muscular dystrophies. A little bit later, plus 1 year, the muscular protein associated with the gene were given the name dystrophy. When the gene fails to produce dystrophy, occurs Duchenne muscular dystrophy. As we said that in Duchenne muscular dystrophies, the protein, particularly dystrophy, absolutely absent. And Duchenne muscular dystrophy is the most common and fatal childhood diagnosis. It develops from the birth and have the high speed of the progression. So, about particularly Duchenne muscular dystrophy. Sorry, for one moment. У меня лекция немного. Duchenne muscular dystrophy. So first, genotype, dystrophy. So then we will say about chromosome. Dystrophin chromosome XP21, recessive. 1/2 of son will have the disease and 1/2 of the daughter will carry. 86% with Palinerjecta mutation, 30 with U mutation. The mutation can change. So 10 to 20 of the U mutation are gonadal mosaic. Illustration of the Duchenne muscle dystrophy as X-linked recessive and carries muscle. No, like we said before. Honest. As I have already said before, clinical honest at 3 to 5 years. Creatine phosphokinase is elevated in affected males, even intraurinary. So, moreover, we will say that clinical manifestation will be at age 3, not earlier. But such children, they have problem with the development of the motor system in early childhood. It means that in normal development, when we see remyelination of the nerve fibers in the little babies, we say that they will sit down at the age of 6 months, need to stand at the age of 7, 8, and walk in 1 year. So usually such groups of the babies, they can sit at age of 8, stand more than 1, and walk more than 1, not like in normal conduction. So clinical manifestation, yes, honest, 3-6 years, then progressive weaknesses, severe hypertrophy of the calf muscle. In illustration, we see in distal part of the extremity. Deformation of the spinal hyperlordosis and will be affecting cardiopulmonary system, will be disorder of the cardiopulmonary system. Then, Gower sign, standing up with helping of the hands pushing on the knee. Failure to walk at age of 9, 13. See the high speed of the progression with the period of the muscle hypertrophy. The speed of the progression will increase with age, and muscle hypertrophy the same, yes, will increase with age. The question is in what? Why we see hypertrophy, especially of the calf, of the distal part of the lower extremity, due to affection of the proximal. Proximal group of the muscle, they are weak due to this, like distal trying to walk by themselves without the help of the proximal. That is why hypertrophy, especially of the calf. Illustration of Gower sign, using hands to push on the leg to stand up. I cannot stand like all others, babies and all other people. Moreover, such groups of the babies, usually little baby at age 2, 3, what they doing? They playing the ball, running with the friends, yes, they're not sitting in one position, and like they don't feel tired, absolutely. And such groups of the babies, they complain onward weaknesses on the legs during running, during playing the ball, yes, and problem with standing. Moreover, when they sitting on the chair, the same, too hard for them to stand up. Illustration of the development of the clinical sign of the Duchenne muscular dystrophy. Those boys, they are from the one family, and we see that in much more elder boy, we see deformation of the spine, hyperlordosis, hypertrophy of the muscle, of the calf muscle, we see, and in the first boy, and in the second, and in the third. They are all brothers. Then the same hypertrophy, deformation of the spine. In this photo, where you will see hypertrophy of the muscle of the calf. And like atrophy of the proximal. I hope you've seen it. Then, standing on the toe, yes, compensative lordosis. If we will see on the distal part and on the proximal, of course, muscle of the calf seem much more larger than proximal groups of the muscle. So, the diagnosis of the Duchenne muscular dystrophy, changing of the gait, absent of the dystrophy. Then odor test, Thomas test, then signs, yes, Myron sign, then decreasing of the what? IQ, increasing of the creatine phosphokinase, myopathic changes in electroneuromyography, and of course, this is genetic analysis. We see DNA mutation. Laboratory. Serum test. The level of the creatine phosphokinase is always increased. Highest levels in the early stages of the disease and usually rated at 10 times the up level normal. Then, carry stage may be detected by elevated of the creatine phosphokinase. As the disease progresses, the creatine phosphokinase level gradually falls, although even in the terminal stages, so it never reaches the normal range. Then, muscular biopsy. Yes, what we will say about muscular biopsy? Variable fiber size, small fibers around it. Then, myopathic grouping of the fibers. Muscle fibers degeneration and regeneration. Muscle fibers internal architectonic, normal or immature. Absent dystrophin stain. Moreover, conduction of the muscle. By what test we can see changing in the muscles. This is electroneuromyography, that the same can give us information about degeneration and regeneration of the muscles. Treatment. We know the principle of treatment. This is etiology, pathogenetic treatment, and the last one, symptomatic treatment. So, we will say that no specific care. It means particularly no etiology treatment. We cannot stop the progression of the disorder. Medications and therapy can reveal the symptoms and slow progression of the disease. Yes? Yes, we cannot stop it, but can do it much more slowly. So, then, what important for such groups of the patient? Of course, this is movement, physical exercises to prevent what particularly forming of the contractures in the muscles due to absence of its normal construction. So then, glutamine, yes, creatine, and all other potential treatments begin study. So, and the drug that we're using, this is corticosteroids. All other treatment will be symptomatic for those groups of the patient. As I said before, prednisolone. So effects prolongs walking by 2-3 years, increased muscle strength, and reduced falls. So then, oxadrenaline, what groups of the drug we can prescribe more? The same for the same effects, yes? And difluzacort. They will influencing in the same way. Prolonged walking, increased strength, but saying for one more time that we cannot stop the speed of the progression. Only make it slowly. Now, another muscular dystrophies that are very common by the clinical sign with Duchenne muscular dystrophy. But we will say what? The speed of the progression slowly, the age of the debut much more elder than Duchenne muscular dystrophies, and prognosis much more better. So, Becker's muscular dystrophies is the mild form of dystrophinopathy. It generally affects older boys and young men and progresses much more slowly. Signs and symptoms are similar to those of Duchenne. So the onset of the signs and symptoms is generally later And so those affected by Becker's muscular dystrophy usually are able to walk until at least age 15 and often well into adulthood. We said before that in Duchenne muscular dystrophies, dystrophy, the protein absent. In Becker's, it's present, but the level decreased. Illustration between differentiation between Duchenne and Becker. We said in Duchenne, dystrophy absent. In Becker, is present, but the concentration is lower than need to be in normal conduction. So another variant of the progressive muscular dystrophies, this is limb-girdle muscular dystrophy. Etiology, the same genetic defect mutation, autosomal receive at chromosome 15q and autosomal dominant at chromosome 5q. Epidemiologically, this is common and more benign. Clinical manifestation. So the illustration of the picture, what group muscles will affect? We said that in Duchenne and Becker, this is what? Proximal group of the muscle of the lower extremity. In the girdle muscular dystrophy, we see affection of what zones? This is pelvis, this is shoulders. So this is a proximal region of the body. And age of onset, this is third decade. Now we can see the picture. So it's invalidization, it's a pity, but the age you see is much more older than the children and patients with Duchenne muscular dystrophy. It's slowly progression, the age of onset more than 20 years. So rare significant scoliosis seen. Treatment absolutely similar to Duchenne muscular dystrophy. The first group of the drug, this is corticosteroids. Not to be true for you, for all types of the progressive muscular dystrophies, we prescribe corticosteroids. Can add vitamin group B and anti-cholinergic drug. So another variant, this is facial scapular humeral muscular dystrophy. By the term, by the name of muscular dystrophies, I hope you understood that this is face, this is neck, and upper part of the shoulder. Etiology, autosomal dominant, defect in the gene, yes, FLG1, and defect in chromosome 4q35. Epidemiology, much more common, female than male. Age of onset, usually late childhood or early adult. And we're not seeing any disorder of the cardiac or endocrinological system as we see in Duchenne muscular dystrophy. Clinical manifestation. Muscular weaknesses were face, shoulder, and proximal region of upper extremity. Sparing quad muscle, deltoidus muscle, distal pectoralis, major muscle, and erector spine. Like, yes, the clinical presentation, like in the previous, yes, but together with the muscle of the face. The illustration of the patient with such type of the muscular dystrophy. Like papier appearance, lack of facial mobility, incomplete eye closed, pucture lips, transferred smile, absence of eye and forehead wrinkles, absent of movement. And you see that on the face muscle, the mimic muscle, they are atrophic. Then, the same illustration of the same muscular dystrophy, or much more elder man. Same atrophy of the interscapular region of the muscle, yes? Then changing the position of the scapula, abnormal. Then hyperlordosis, it's rare for this type of the muscular, of such type of the muscular dystrophy. Then distal muscular dystrophy. By the term understanding that will involve distal groups of the muscle, symmetrical and upper and lower extremity. Sensation will be absolutely normal. It going like in ascending direction, like typical for polyneuropathy, yes? But we know that for polyneuropathy will be affection and of sensory fibers. Here, only motor. Going from the distal part and spread in the proximal direction. Ocular muscular dystrophy, very, very rare type of the muscular dystrophy. Here suffering extraocular muscle, appearing extraocular muscle weaknesses due to this diplopia, yes, double vision, and limit ocular movement. May involve proximal upper extremities and have the slowest speed of the progression. So, the question that I want to ask you, maybe you will answer. The disorder in what we see, diplopia, limited ocular movement, and involving of the proximal groups of the upper extremities. It can be what another disorder, who remember? For today's classes we discussed. Ну что? Esther, what is
Myasthenia gravis?
Myasthenia gravis? Absolutely right. That is why sometimes having confusion in the myasthenia gravis and ocular muscular dystrophy can be such a typical variant of myasthenia gravis when we see very high level of the antibodies in the neuromuscular junction. It absolutely closed the receptors and we can see negative endorphinium test. And we will say maybe this not myasthenia gravis, is endorphinium test negative. It was one of the diagnostic criteria. Maybe this ocular muscular dystrophy, yes? That is why need close to differentiate. But not need to forget about what? That such variant of dystrophy can be seen, but very, very rare. Moreover, proximal group of upper extremities, both. In myasthenia gravis, what usually only on one side. I hope you understood the differentiation of them. No, of course, we will need to do additional methods of research to prove or exclude our point of view. Так, oculopharyngeal muscle dystrophy. The first sign of this type of the muscular dystrophy, dropping of the eyelid, followed by weaknesses of the muscle of the eye, face, throat, and resulting in the difficult of swallowing. Progression very slowly. Signs and symptoms appear in adulthood. Usually, this is person in the period of the 40, 50, and 60 years. The same variant, oculopharyngeal muscle dystrophy, we said involving what groups of the muscle? This is muscle of the eye, face, throat, and dysphagia. The same need to differentiate with myasthenia gravis, yes? Moreover, we will say that if the person of age 40, 50, 60 can be seen secondary myasthenia gravis like Lamberta-Itana syndrome. Illustration of the oculopharyngeal muscular dystrophy. Autosomal dominant, age third decade, ptosis in middle life. Affection only of the face, then throat, and difficult due to this difficult to swallow. And clinical presentation more that can be seen: dysarthria, dysphagia, frequent coughing, and repetitive regurgitation, weaknesses of the muscles of larynx and pharynx. Так, ну смотрите, from this chart, if you want, you can do photo. If you want, you can write. I think photo much more better, and quickly. This is differentiation of all types of the muscular dystrophies. Age of forest, male or female, what muscle involves. I think that for you it will be, and in your exam and in your classes, informative. So tell me please, did you do the photo?
Yes.
I can change the slide, yes?
Yes, ma'am.
Okay. And then continue on it. Ready?
Yes.
Okay. And the next will be myasthenia gravis. But we will do in such way. So for 5 minutes, give me please code now from the department, our department. So need to recall, okay, Madam Irina Kola. 5 minutes and we will continue. I am not stopping the conference, okay?
Okay, ma'am.
So we'll continue. Yes, and the next topic, this will be myasthenia gravis. One moment, I will open. So tell me, please, is it open?
Yes, ma'am.
Open the cell, yes?
Yes, yes.
Okay, so we'll begin. Definition firstly, yes, what is myasthenia gravis? This is the disease characterized by episodic muscle weaknesses caused by loss of dysfunction of acetylcholine receptors. In another way, we can say that myasthenia gravis, this is the disorder of neuromuscular junction leading to appearing of the pathological muscle weaknesses. As you like. This is not a mistake. You can describe it in your classes in one way or in another. So, acquired myasthenia gravis, this is immunological disorder, autoimmune disorder, in which antibodies are directly gained the postsynaptic nicotine acetylcholine receptors. We see block, downregulation of these receptors and reduces the probability that nerve impulses will generate a muscle action potential. In conclusion, by this slide, what we can say that myasthenia gravis, dysfunction or disorder of the neuromuscular junction, we see normal level of acetylcholine, but antibodies that closed or blockage the receptors of the postsynaptic membranes, nicotine acetylcholine receptors. Due to this inability of the impulses to go through the neuromuscular junction, and in clinical presentation, appearing pathological muscle weakness. Etiology. As we said before, this is a disorder of the immune system, or this is autoimmune process. Acetylcholine, I hope you remember, this is the neurotransmitter that involved in the transfer of the information to muscle tissue. In myasthenia gravis, we see antibodies that destroy acetylcholine receptors in neuromuscular junction and preventing the nerve impulses from reaching muscle. And this results, as we said, in rapid fatigue, or another term as pathological muscle weakness. But risk factors, for myasthenia gravis. Myasthenia gravis is associated with other autoimmune diseases. For example, in the family, when the members of the family suffering from rheumatoid arthritis, scleroderma, yes, they increase the risk to the myasthenia gravis for another members of the family, like genetic predisposition. In what particular? We know that rheumatoid arthritis and scleroderma, they are autoimmune disorder, dysfunction of the immune system. Thymoma. Firstly, what we say about the thymus. Thymus is a gland of the immune system that responsible for forming the immune answer from the birth of the babies till the second decade of the period of life, 24 hours. And approximately 15% of patients of myasthenia gravis have thymoma or hyperplasia of the thymus. Circulation of the material antibodies to placenta result in transient neonatal myasthenia gravis. A little bit later, much more close, we will say about it. So, genetic defect results in congenital myasthenia gravis. Transient neonatal myasthenia gravis in future will not be seen in the people, in the patients. So, Myasthenia gravis, as we said before, common disorder of the neuromuscular junction transmission. Young owners is often associated with hyperplasia of the thymus. Timoma is more commonly seen in later onset disease. In our classes today, we said that this is secondary myasthenia gravis, and usually the results of this timoma, the tumor, this is oncological changes in the mediastinum, and this is secondary to myasthenia gravis like Lamberta-Itana syndrome. More common occurs on women between 20-40 years. In pathogenesis, we will say that antibodies are directly against the postsynaptic nicotine acetylcholinergic receptors. So those antibodies directly block the binding of acetylcholine and lead to complement-mediated attack and internalization of receptors. No, we said about it before. So, and the end result is restoration of the end plate with loss of normal conjunctional force and a reduction in the concentration of the receptors. I hope it's understandable for everybody, yes. So, thus, even through acetylcholine is released normally from the postsynaptic body. Its effect at the end plate is reduced, with the results that the nerve impulses is less likely to generate the muscle action potential. Due to this, the dysfunction of neurotransmitters and pathological muscle weaknesses in patients with myasthenia gravis. Illustration of two synapses. This is normal synapse with normal neurotransmission of the acetylcholine, and they go into the receptors. Here we see myasthenia gravis synapse. We see defect of the receptors, blocks of several of them, and decreasing its sensation for the acetylcholine. Due to this, we see clinical presentation. Another illustration of the blocking out antibodies that cause myasthenia gravis. And this is the same that we saw before, but in another picture. What forms of myasthenia gravis we can describe? Juvenile or adult, neonatal, this is transient myasthenia, congenital, drug-induced myasthenia, drug-induced myasthenic syndrome, and ocular myasthenia gravis. We have a great variety of different classification of myasthenia gravis. Juvenile and adult forms of myasthenia gravis. So typical begin at any age, but common 20-40 years. Less common age 10 and after 65. Yes, after 65, we said before that it's usually myasthenia syndrome. So, circulation of acetylcholine receptors antibodies are demonstrated in 85% of these patients. Typical form of myasthenia gravis and other forms are rare. So, juvenile and adult forms of myasthenia gravis, those forms particularly, much more percent seen and much more information of this form you will have and will discuss on your classes, much more detail. About neonatal myasthenia, this is transient where 20% of infants born to myasthenic mother have a syndrome that characterized by impaired sucking, weak crying, lip links, and sometimes respiratory disorder. But symptoms begin in the first 48 hours and may be seen only for several days or weeks, after which the children will become normal without any specific therapy. Symptoms will disappear because the level of antibodies will decrease. Congenital myasthenia. So antibodies to acetylcholine receptors, they are not found, but there are decremental responses to repetitive stimulation. So what it means, a little bit later we'll see much more detail. This is particularly investigation in such additional methods of research like electroneurommyography, with antibodies absent, but electroneurommyography showing positive results after repetitive stimulation. Yes, on the next slide will be much more detail. Cholinesterase drugs may help some of these disorders, but patients should be warned that suddenly a panic spell may be induced by mild infections. Drug-induced myasthenia. This is like myasthenic syndrome. So, occurs in patients who receive antibiotic drug, diphencylamine, who receive some mild relaxant drug, then who receive anticonvulsant drugs, groups of the drugs, yes, that particularly influencing on the speed of the nervous impulse. The clinical manifestation and acetylcholine receptors antibody titers are similar to typical adult myasthenia, but if disappear after the drug administration is discounted. No specific treatment here, like we're saying about juvenile and adult myasthenia gravis that need to give corticosteroids, that need to give anti-cholinergic and so on. Ocular myasthenia gravis. This is a subclass of the generalized disease involving only extraocular muscle. But to say, not to have the confusion in one. In classes, we say local form of myasthenia. Here we say generalized. This is the great question for discussion. Different point of view. But ocular myasthenia gravis, its prognosis, it's not such worse like variant of the juvenile and adult when we see Bauer syndrome. Illustration of the ocular form of the myasthenia gravis. Patient looking down, after that to ask the patient to open the eye, and we see on one eye, it's open. In contralateral side, we see cryptosis. With fiction of the vision, cryptosis growing, and we see total closing of the eye or by the term ptosis. The first patient able to open the eye, and after that appearing muscle weaknesses, and we see ptosis. About 17% of the thymus gland from adult patients with myasthenia gravis are not involved and weigh more than known. The glands show lymphoid hip hyperplasia. So, immunocytological chemical methods indicate that these germinal centers contain B cells, plasma cells, HLA cells to their positive T cells, immune disorder, answer of the immune answer. Both normal and myasthenic glands contain alpha-tymazine, a thymic hormone that is important for the tail cells maturation. So another 10% of myasthenic thymus gland contain tumors or lymphoepithelial type. The lymphoid cell in this tumor are T cells. You see different there. So the tumors tend to occur in all patients, like we said before. The tumor is made in the pleura, pericardium, blood vessels, and may seen out more distant thoracic structures, including the diaphragm. So, the symptoms of myasthenia gravis have three general characteristics that together provide a diagnostic combination. So, the weaknesses varies in the course of single days, sometimes even within a minute. And it varies from day to day or over a long period of the time. There's appearing and disappearing without any treatment. Patient doing something, sign appearing, having the rest disappearing. Patient with myasthenia gravis also never complain on fatigue or symptoms that might be constructed as what you expect when there is insufficient respirational muscle weaknesses. So the second of myasthenia gravis is distribution of the weaknesses. Ocular muscle usually affected first in about 14% of the courses. This is ptosis, diplopia. This can be preptosis and can be dynamic strabismus. Our other common symptoms affect facial or oryngopharyngeal muscle, results in dysarthria, limited or facial movement. So then, limbs and neck weaknesses is also common, but in conjunction with cranial weaknesses. Involvement of respiratory muscles may cause a problem with ventilation. First, in conclusion, we say ocular muscle, yes, then oryngopharyngeal muscle, then cranial nerves, bulbar syndrome, dysarthria, dysphonia, and dysphagia, limbs, neck weaknesses, common and respiratory disorder. So here we see symptoms yes, by different involving of different groups of the muscle by the localization of the affection neuromuscular junction. This is the illustration that can show for us what that affection distal part of the upper extremity, affection neck, yes, then shoulders muscle, yes, muscles of the face, and so on. So the next third characteristic of myasthenia gravis is the clinical response to cholinergic drug. This occurs so informally that has become part of the definition, but it may be difficult to demonstrate in some patients, especially with pure ocular myasthenia. So, the signs. Weaknesses of facial levicular muscle, as we said before. Yes, ptosis, and weaknesses of the facial of the iliac muscle. Weaknesses of ocular muscle may cause paralysis or weaknesses of isolate muscle. Paralysis of conjugation gaze, ophthalmoplegia is one or both eye can be affected. So weaknesses of oropharyngeal and lip muscles can be shown by appropriate tests. Respiratory muscle weaknesses can be detected by pulmonary functional test. The level of oxygen and saturation. Muscle wasting of variable degrees is found about 10% of courses, but is not focal. Gesticulation don't occur unless the patient has received excessive amount of cholinergic drug. Gesticulation, this is the answer for high dose of the cholinergic drug. Sensation not affected, normal. Reflexes will be present. even in weak muscle, they are not affected. Weaknesses of the facial muscle in myasthenia gravis produces a characteristic expression of the face. Now here is affections of the masseter, jaw. This is weaknesses of the chewing and of the ocular muscle. Facial dropping in myasthenia gravis. You see how it will be different between ptosis and facial dropping. Like variant of the Bell's palsy seeming, yes, but Bell's palsy, of course, this is much more rude and much more colorful for clinical sign. Here is slight dropping of the face. Ptosis. And on the contralateral side, when you look into the eyeball, it seems the same, that it's abnormal, yes? It's much more like wider than need to be. Why it's seen? This is compensative mechanism of the not affected muscle. Yeah? Then, ptosis in myasthenia gravis due to the facial muscle weakness. See? Yes? This like the angle of the eye going down, but just will open. In previous, this is the angle of the eye normal, but we see weaknesses of the levator palpebral muscle. So upgaze palsy, inability of the patient to look in upside, appearing ptosis in both eyeballs. Diagnosis, clinical picture. Then enderphonium test, enderphonium anticholinergic drug. Then electrophysiological test, electroneuromyography. Serological test, level of the antibodies. CT scan and MRI. No, CT scan much more informative here of mediastinum. This is what to prove for risk thymoma. A neuromuscular transmission study. This is the same electrophysiological test, variation of the electroneuromyography. Enderphonium test. We said enderphonium is an anticholinesterase drug of short duration of action, less than 5 minutes. So, if the patient has myasthenia gravis, muscular function improves suddenly and briefly after the injection of enderphonium. This test can also differentiate between myasthenic crisis and cholinergic crisis. Yes, myasthenic crisis seen in patients with myasthenia gravis, particularly who without treatment, for example, was for a long period of the time or forgot to take some drugs. Cholinergic crisis seen in what groups of the patient? When patient took a great amount of anticholinergic drug due to this appearing cholinergic cry. So, patient with myasthenia gravis after injection of the enderphonium will improve, but if it's cholinergic cries may become worse. In these cases, we need to use atropine. Electrophysiological test. So, in 16% of affected patients, neuromuscular transmission studies show a decremental response in the amplitude of compound muscle action potential with repetitive nerve stimulation to 3 Gz. How it will looking like? In electroneuromyography, we doing several blocks of the stimulation. Usually it's 3 blocks, maybe 5. In each blocks, every second will be repetitive stimulation of 2 or 3 Gz. In the first block, the answers will be normal, motor answers. After that, will decrease. After that, much more decreased, and then stopped. Yes, this means decremental response in the amplitude with the repetitive stimulation of nerve. First answer is normal, after that we see pathological muscle weaknesses. Serological test, acetylcholine receptors antibodies are found. So usually 19% of the patients with generalized disease and 15% of the patients with ocular form. But we will say that not in all cases antibodies level do not correlate with the disease severity. Sometimes people have very high level of the antibodies but less clinical signs. And in another cases, less level of antibodies, much more worse clinical sign. Serological test, we see acetylcholine receptors antibodies that close the receptors. This is changes in the neuromuscular junction common for myasthenia gravis. We saw the same picture before. CT scan and MRI examination of mediastinum may detect associated tumor or thymoma or hyperplasia of thymus. Of course, too hard to find the hyperplasia of the second stage, and 100% too hard to see because this is only cytological methods of research. Pulmonary function test, spirometry, done for those groups of the patient who have respiratory muscle weaknesses to see the level of oxygen. CT scan illustration of the mediastinum. Thymoma seen. CT scan with large thymoma. Then laboratory investigation. Of course, like in all the patients, we do an examination of the blood, urine, cerebrospinal fluid exam. Usually, this routine examination absolutely normal. Electrodiagnostical abnormal is progressive decremental, as we said before, in amplitude of muscle action potential evoked by repetitive nerve stimulation to 3 Hz. Usually, we investigate it in electroneurommyography, 3 muscles, that's a 3 nerve muscle system. Median tenor, ulnaris hypotenor, and the last one, this is accessory trapezius. In microelectrode study of intercostalis muscle, the amplitude of the mintura and plate potentials is reduced at about 20% normal, caused by decrease in the number of acetylcholine receptors available to agonists applied by microtonophoresis. Single fiber electromyography. A small electrode measure in the interval between the potential of the muscle fiber in the same motor unit. So, in this interval normal varies and phenomenon called jitter. This is the same like electrical periodical stimulation that we said before. So the jitter, the same, not same investigation, by same result. The jitter is increased and impulses may not be appear at expected time. This is called blocking. So the standard electromyogram is usually normal. Just because I will show how it's looking like. After that will be the picture. Antibodies. We have already said about them, yes? 85% of the patients with all ages in human muscles and used as the test antigen. Here, illustration of the stimulation variant of electroneurommyography. Like we said, decrement amplitude of muscle action potential in repetitive stimulation. Electromyogram needle to the muscle and register the impulses. This is needle electrode. It's looking like in this way. Conduction of muscle itself may show in myopathic pattern. They're looking like in such variant. Now, the class is much more detailed. We will explain what it means. How to differentiate myasthenia gravis? This is muscular dystrophies, as we said before, lateral amyotrophic sclerosis. This is progressive bulbar palsy, botulism intoxications, Lamberta-Eaton syndrome, very important point, secondary myasthenia gravis syndrome, myasthenia syndrome, in what we see tumor, usually oncological changing in the mediastinum in the age more than 65. Treatment, anticholinesterase on the first place, then plasmapheresis, then corticosteroids, then immunosuppressive, and the last one, time-acting, timers-acting. See, on the first place, not corticosteroids, yes? Anticholinesterase drugs. Pyridostigmine, this is anticholinesterase drug. Dose 60 to 140 per milligrams. This is maximum. 3 to 4 hours in the most common used anticholinergic drug. So about the dose, it must be careful adjusted to individual requirement. And patients who have severe dysphagia with difficult swallowing, like Bowler syndrome, in the morning can use long-acting capsules at night. So this drug can cause abnormal cramps, diarrhea, decreasing of the blood pressure, which are less severe with pyridostigmine than with neostigmine for some patients. If we see such results, we're giving atropine. So then anticholinergic drug may not reduce all symptoms, especially in extraocular muscle paralysis. So that's so strange. This is not such worse variant of the form, but too hard to treat. Ephedrine may be tried in such situation. Then corticosteroids. They're useful in long-term treatment and are less useful for crisis. So azathioprine, methylprednisolone, we can use. But a great question for discussion, I mean corticosteroids, need clearly and very carefully to think, is it necessary or no? Because those dose, high dose of the prednisolone, so 60, 70 milligrams, they will influencing on the level of blood pressure, rate of the heart, and level of the glucose. That's why if we may not give it, and maybe it's not necessary for the patient and will have positive treatment under anticholinergic drug, we will exclude corticosteroids. Thymectomy. Thymectomy indicated in much more percent of the patient. And so in 18% of the patient, they go into the remission for long period of the time. Etymoma is present, must be exercised to prevent spread with the mediastinum. Plasmapheresis may be used before thymectomy in refractory patient and during crisis. Those are not always we're using plasmapheresis. So thymectomy received for patients with severe disability because the operation had a high risk. What high risk? Age of the patient, location of the tumor, yes, and additional maybe disorders of the patient like arterial hypertension, diabetes mellitus, something else. The techniques of thymectomy. This is seen by endoscopy. So, a radical operation, opening the chest, and doing the radical operation. Prognosis. Symptoms of myasthenia gravis usually progress to maximum severe with 3 years. After 3 years, patient usually in stabilization or improved. So patient over the age of 14, those with a short history of the severe disorder and those with timoma have a worse prognosis. So much more younger people, usually they have long period of the remission and absolutely can live normal life. And prevention. Myasthenia gravis cannot be prevented, but can be under the control. And so we can see the appearing of the clinical signs due to some prevention factors, due to risk factors. Emotional stress, exposed to extreme temperature, fever, different illnesses. So hypokalemia, a low level of potassium in the blood, taking some medications, some groups of the drugs, they can provocate the attack of the myasthenia gravis. So, okay. Now, tell me please, what question do you have about myasthenia gravis and progressive muscular dystrophy? All clear for you?
Yeah, clear.
Okay, now I hope on the classes, much more detail we'll discuss and we'll repeat, yes? And if everything clear, тогда for today, we will finish our lecture, okay?
Okay, well.
Okay, so wish you good day. Group number 23, 24, waiting for tomorrow classes at 9 at 11. Yes, and I hope the information all clear for you and will be useful for your classes. So wish you good day. Bye.
That's Daniel.